You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 12th, 2024. This week, the first ACC Recap. I will review the Danger Shock trial, including a sobering JAMA study on Impella use, the Reduce AMI trial, the Prevent trial, and the EMPACT MI trial. First of all, I want to thank the European Heart Rhythm Association for the invite to Berlin. Also, a specific thanks to ERA future president, Dr. Helmut Purelfender, for getting me to run the Berlin Marathon course. Running with 40,000 people is a first for me, and it was so cool to help promote their Pulse Day initiative. But even cooler was meeting so many young people. To everyone who came up and introduced themselves, I say a huge thank you. It boggles my mind how many different countries were represented, and what a great feeling it gives me to know young people find this podcast helpful. Thank you times 1,000. Now, even though I was participating in ERA in Germany, I was watching the ACC meeting in Atlanta, and gosh, what a great bunch of trials there are now to discuss. I'll only do a few of them today, and we can do others next Friday and perhaps even a third day to get all of the important trials in ACC. First, Danger Shock trial. Okay, the microaxial flow pump is the generic name, but that is hard to say, and so I'm going to make an exception and use a brand name and call it the Impella. Now, 5 reasons make the Danger Shock trial of Impella versus standard care in patients with an AMI-related cardiogenic shock one of the most important trials in recent years. First, cardiogenic shock due to acute MI is a highly lethal disease, and any therapy for such a bad disease is important. The Impella support device comes with potential serious harms like limb ischemia, bleeding, hemolysis, etc. Impella is a costly device. Fourth, despite more than a decade of use, no previous trial has shown it to be effective. The enthusiasm for this device, despite no RCT level of evidence, has always surprised me. I mean, in trials, Impella underperformed against balloon pump, and the balloon pump had previously shown to be no better than standard of care. Now, the final reason for the importance of Danger Shock is that Danger Shock showed cardiologists that it is possible to do trials of terrible diseases, such as an AMI-related cardiogenic shock. Dr. Jacob Moller from Odense University in Denmark spent 11 years randomizing 355 patients with AMI-related cardiogenic shock. It was Impella versus standard of care. He had highly selective entry criteria. Patients had to have real shock, soft blood pressure, high lactate, pressors, but they could not be neurologically too far gone. The primary endpoint could only be mortality. The time of the measurement of this was not at 30 days, but 180 days. Now, you probably already know the results. Patients in the Impella arm had a 26% lower risk of death, a hazard ratio 0.74, and the confidence intervals went from 0.55 to 0.98, so the p-value calculated at 0.04. Now, there was a 4x higher rate of serious complications in the Impella arm. This included bleeding, 2x, limb ischemia, 5x, renal replacement therapy, 2x, and sepsis with positive blood cultures, 3x. Yet think about it, all of these adverse effects could easily be on the causal path of death. But death was still lower in the Impella arm. It was 46% versus 58%, so a 12% absolute risk reduction. My comments. First, congratulations to Dr. Moller and the Danger Shock team. It's an impressive thing to stay with the trial for 11 years. Now, as a neutral Martian, outside observer, and even rare user of Impella during VT ablations, I've been skeptical of the device, due mainly to the disconnected enthusiasm of the proponents despite the total lack of trial-level support. But my U.S. colleagues, they say, John, we don't need trials because we take care of these patients, and we can tell you that some patients don't make it out of the lab without this device. Well, now, Danger Shock strongly supports their contention that some patients are indeed saved, and I'm happy that is true. It's good. And I'm not deterred by the p-value here of 0.04. The confidence intervals lend themselves to as much as a 45% lower rate of death. And I think we need to give trials that have control arm death rates of 60% at 6 months a bit more statistical leeway. But Danger Shock does have some important caveats that affect translation to the bedside. Mainly, Danger Shock applies to a very specific patient. These patients had to be sick with a median arterial lactate of 4.5 millimoles per liter. They had to have impaired left ventricular ejection fraction. The median EF was 26%. They could not present late. The median time to randomization was 4 hours. But they could not be too sick, say comatose, or have RV pump failure. Now, I'm glad that Dr. Moeller took care to select patients who were most likely to benefit. Now it's our job as cardiologists to apply this therapy to patients similar to those in Danger Shock. These results should not have bearing on use of the device for other indications, say high-risk PCI. This too could be studied in RCT format. And a final word on regulatory matters. I wrote on Twitter yesterday that had the FDA required approval with evidence, Danger Shock could have been done in 11 months, not 11 years. Before it was widely accepted, because imagine if this trial was negative, like all the previous Impella trials. Think of the harm we would have caused and money we would have wasted. If Danger Shock came out negative, it would have been as ugly as the antiarrhythmic drug reversal in the CAS trial. Okay, second topic today, and related to Danger Shock, is a JAMA paper looking at Impella device manufacturer payments to cardiologists and use of the device. This paper, led by Dr. Sanket Dhruva at the UCSF, along with colleagues like Joseph Ross at Yale and others, studied the association between payments from Abiomed, the maker of Impella, to doctors and then the doctor's use of the device. Now, this paper was definitely not a late breaker at ACC. In their introduction, authors note the use of the Impella support device for cardiogenic shock has doubled over just a 2-year period from 2015 to 2017. Given the lack of RCT support during that time, the authors rightly considered industry payments as a potential cause. And they used the Open Payments database in the U.S., which mandates documentation of any industry money a doctor receives. They then linked payments to a billing and a sample of Medicare fee-for-service beneficiaries. They had 4 main results. First, 56% of cardiologists who placed an LVAD received payments. The median value was low at $164. About 6,000 cardiologists receive LVAD payments in individual years, and of these cardiologists, 23% performed at least one LVAD, whereas among the 11,000 cardiologists not receiving LVAD payments, 9.5% performed at least one LVAD. They then did a multivariable analysis, and receipt of LVAD payments versus no receipt was associated with a 2x higher rate of any LVAD use in the year of payment, and a 1.9x higher rate of LVAD implant in the subsequent year. And I think the final is the most important. The highest risk of LVAD use was observed in the highest tertile of LVAD payments. So my comments: as much as we celebrate the positive results of Danger Shock, we should also not look away from this analysis. I'm sorry to say it is unseemly. People outside the medical guild like to think of their doctors as a trusted, neutral advisor, like a judge, not influenced by anything other than the patient's best outcomes. This analysis casts doubt on the presumption of neutrality. Docs who receive payments were twice as likely to use the device than docs who did not get payment, and the more you are paid, the more devices you use. These two associations may not prove causation, but they are both worrisome associations. And to those who say, naively, I would add, that industry payments don't affect their choices, how exactly do you refute such an association study? My answer is, you cannot refute it. Drew and colleagues have simply documented human nature, and a likely reason this procedure gained popularity despite the lack of data. Industry money has two effects. One is to specifically influence the actions of a single doctor. But the larger effect is to create an entire therapeutic fashion. That is, if big-name docs are doing a procedure, and if the docs across town are doing it, then perhaps we should do it as well. Now, sorry again, I feel funny about this, but I'm going to moralize a little bit. I don't think this is right. In the first half of my career, I was susceptible. I went to dinners, took money to speak from companies, but I don't anymore, and I don't think it's necessary. For instance, I learned conduction system pacing without taking money from industry. It is possible, and it is probably better, because if education is from industry, it is not neutral. One thing that makes me quite sad about my field of EP is that so much of our education comes from industry. All right, third topic, REDUCE AMI trial. Speaking of important trials, REDUCE AMI tested one of cardiology's strongest dogmas, that is, use of beta blockers after MI. The seminal trials that established beta blockers, BHAT, ISIS-1 commit date back decades ago. MI care now looks nothing like it did in the pre-internet age. The likely benefit of beta blockers after an MI stem from the reduction of arrhythmic death and prevention of complications due to wall stress, for instance. Acute revascularization in MI prevents much of the myocardial damage that used to occur in the era of BHAT and ISIS-1. The investigators of REDUCE AMI, led by Troels Jendegen, sorry for that pronunciation, from Lund University Hospital in Sweden, they asked a simple question. Do beta blockers still reduce death and recurrent MI in patients with preserved LV function who just had an acute MI? Emphasis there on normal EF. REDUCE AMI investigators had priors to work with, right? A meta-analysis of 60 trials of post-MI beta blockers reported that the later trials versus the earlier beta blocker trials no longer found any benefit from beta blockers after MI. Now, this trial was a little different than a typical industry-sponsored mega trial. First of all, they used a Swedish registry to assess outcomes, and there was no placebo tablet, only standard of care arm without beta blocker. And here were the results. After 3.5 years of follow-up, the primary endpoint of either death or MI occurred in 7.9% of the beta blocker arm versus 8.3% of the control arm. That's a hazard ratio of 0.96, confidence interval 0.79 to 1.16. The p-value very large at 0.64. Other secondary endpoints, such as CV death, hospital admission for AF, heart failure, also did not differ between the two groups. Neither did safety endpoints, such as bradycardia, hypotension, or hospitalization for lung disease. Now, some purists are going to argue that the confidence intervals were wide and perhaps this trial was underpowered. They would note that the lower bound of 0.79 indicates a possible 21% benefit, while the upper bound of 1.16 allow for a 16% harm. They might say that evidence of an absent effect is a very high bar, and in this case, there may be more of an absence of evidence. Now, comments. Let me first argue that the purists in this case, I think, are wrong. First, the event rates of 2.4 and 2.5% are nearly identical. A p-value of 0.64 indicates that if we assumed there was no effect of beta blocker, then this observed data would not be surprising at all. Second, the reason those confidence intervals are wide is because there were fewer events than the investigator expected. That's important because if you have low event rates, it's harder for any therapy to lower an already low number. Again, this strengthens confidence, I think, in the no result. Another reason I'm not swayed by the purist is the prior knowledge. I realize that the statistical plan here was frequentist, which does not take into account prior beliefs. But we are doctors and we can think in a Bayesian way, and consider our pretrial expectations. That is, that based on a 60-trial meta-analysis, which showed no benefit in the later beta blocker trials, we expected no benefit from the beta blockers. I wrote in my column on this that's up that the results of reduced AMI are like a negative stress test in a patient with no risk factors and atypical chest pain. Now, as it so often is, the two main take-home messages here are A, beta blockers likely offer no benefit to post-MI patients with a preserved DEF, which is great to know because beta blockers come with potential side effects and reduction of pill burden is always a good thing. But the second take-home message is that evidence-based practice needs expiration dates, right? Beta blockers exert the same pharmacodynamic effect now as they did in the 1980s. What has changed is the disease. When diseases change, they just changed in MI, but they also change, say, the risk of sudden death and heart failure, we need new trials. Listeners also can note that there are at least 3, maybe more, large RCTs testing a similar question. These trials, like DanBlock, Beta MI, and Reboot, will likely confirm the results of reduced AMI. All right, next topic is the PREVENT trial. And this is a fun topic. We learned early on in our training that the most likely lesion to cause an acute coronary syndrome is a young, thin-walled, friable, but non-flow limiting lesion. A vulnerable plaque, if you will. Highly stenotic, old, chronic lesions are less apt to rupture or clot off and more likely to cause angina. So the holy grail of cardiology is to A, identify, and B, treat these vulnerable plaques. South Korean investigators, led by Sung-Jung Park, attempted to study one approach to this foundational problem. To date, all of the evidence we have suggests PCI of lesions should be reserved for highly obstructive, symptomatic, medically refractory lesions or those during an ACS. Park had another idea. Let's take those lesions that are visible, say more than 50% on angiography, but non-flow limiting, a negative FFR greater than 0.8, and do intracoronary imaging on them. And if the imaging shows 2 of 4 high-risk features for plaque vulnerability, then let's randomize those patients to preventive PCI versus medical care. Now, patients had to get to a cath lab to be randomized. The target lesion could have been the only lesion, or it could have been a second one, say after an ACS lesion was stented. Now, they screened over 56 patients in South Korea, Japan, Taiwan, and New Zealand to enroll about 1,600 patients in the trial. The primary endpoint was a composite MACE, a sort of a complicated one. CV death, target vessel MI, ischemia-driven target vessel revascularization, or hospitalization for unstable angina. The trial had up to 7.9 years of follow-up. The median was 4.3 years, but the primary endpoint was assessed at 2 years. And the results were positive. At 2 years, primary outcome event occurred in 3 patients, that's 0.4% in the PCI arm, versus 27 patients, that's 3.4% in the control arm. The authors reported this as an absolute risk difference of minus 3.0%. The 95% confidence intervals went from minus 4.4% to minus 1.8%. And that p-value is highly statistically significant at 0.0003. Now, if you convert this to relative risk, it yields a hazard of, get this, 0.11, which is an 89% risk reduction. Each component of the primary endpoint favored the PCI arm, and a secondary composite endpoint of death or any myocardial infarction or any revascularization also favored PCI, and the risk difference here was a statistically significant minus 2.2%. The Kaplan-Meier curves separated early, then they remained parallel, suggesting that all of the benefit occurred in the first number of months. I wrote about this study, and I'll link to it, and I started by saying how much I liked the trial. It was so bold and novel. But, my friends, it's very early. There are many reasons to be cautious. Sadly, the authors were not cautious in their conclusion statement and in their enthusiastic tone in their discussion. They wrote that the results, quote, support consideration to expand indications for PCI to include non-flow limiting high-risk vulnerable plaques. I don't think this is right for many reasons. First, there were a really small number of events in this trial, 3 versus 27, mostly non-fatal events, in a trial of 1,600 patients. The significant results at 2 years did not remain significant at 4 and 7 years. Now, that's important because you'd think that if this intervention PCI for vulnerable plaques was so great, the accrual of more events would strengthen, not weaken, the effect size. A third reason for caution, and this is not their fault, is the open label design. 2 of the endpoints are susceptible to human decision-making. So there's an issue of subtraction anxiety. In other words, patients who did not receive a stent or get fixed may have been more apt to be admitted for unstable angina or have a target vessel revascularization. Think FAME-2 trial. There were also more patients taking P2Y12 inhibitors in the PCI arm, and that's another reason they may have had fewer events. There was also missing data in 50 patients, and that's not a small number given that the delta was only 24 events. Finally, and perhaps most importantly, there is the matter of translating this data to real life. Imaging of coronary lesions is not as common as in some geographies. What's more, 2 of the 4 imaging techniques that they used involved complicated devices that are not universally available to many interventional cardiologists. All of this makes me say this is a great study. It gives me some hope, but it's very early. Medical science is hard. Major achievements are rare. We need a lot more confirmatory evidence. I think it would be a terrible mistake for interventional cardiology to start doing what they consider vulnerable plaques based on just this evidence. We need more trials. And if this pans out, it could be a Nobel Prize level advance, and Dr. Park and his colleagues would get the credit as trailblazers, so good on them. All right, final topic, EMPACT MI trial of Empagliflozin in the post-MI setting. Empagliflozin is a sodium glucose cotransporter 2 inhibitor drug, and this new class of medications benefits patients with diabetes, heart failure, and chronic kidney disease. But, as I described earlier in the REDUCE AMI trial of beta blockers, the post-MI setting is a much higher bar. It's a higher bar because our MI therapies are really good, even when there is LV dysfunction. Think ACE inhibitor. This trial was simple. EMPACT randomized one group to EMPA and the other to placebo. The primary endpoint was hospitalization for heart failure or death from any cause. EMPACT entry criteria required either an LVEF of less than 45% or congestion requiring therapy. Trial has also added an enrichment factor, such as age greater than 65 or diabetes, and the idea is to enrich the population of patients who could benefit. Patients in the trial, though, were on excellent background therapy of renin-angiotensin blockers, MRAs, and beta blockers. Similar to REDUCE AMI, the main results were non-significant. After 17 months of follow-up, a primary outcome event occurred in 8.2% of the patients in the EMPA arm versus 9.1% in the placebo arm. That hazard ratio is 0.90. Confidence intervals go from 0.76 to 1.06, and the p-value is 0.21. Now, the actual primary outcome events were split nearly evenly between death and heart failure hospitalizations. All-cause death did not differ in either arm, 5.5 versus 5.2%. Heart failure events were lower, but not enough so to affect the primary endpoint. For instance, first heart failure events were 23% lower in the EMPA arm, and the total number of heart failure hospitalizations was 33% lower in the EMPA arm. The rate of death, however, due to cardiovascular causes was exactly 4% in both arms. Now, of note, the authors, interestingly, published in a separate manuscript in circulation the results of the heart failure hospitalization endpoints. So, of course, they added a positive trial to this negative trial, which was in New England Journal. Adverse events were similar in both groups. Okay, my comments. The SGT2 inhibitor story after MI is similar to the beta blocker story. As the risk of the primary outcome event goes down, new therapies struggle to make clinically important incremental gains. EMPACT also comports well with the non-significant DAPA-MI trial of dapagliflozin in the post-MI setting. DAPA MI, which is published in the New England Journal of Medicine Evidence Journal, may technically have a positive endpoint because the authors changed it to a win ratio with soft endpoints that drove the positive result. But like the IMPACT trial, the hard endpoints of heart failure and death in DAPA MI were not different. The failure of SGLT2 inhibitors in post-MI care is also similar to the non-significant Paradise MI trial of the angiotensin receptor neprilysin inhibitor sacubitril/valsartan versus ramipril. In that trial of post-MI patients with a mean LVEF of 36%, sacubitril/valsartan did not significantly reduce the composite primary outcome of CV death or incident heart failure versus ramipril. Now, as I wrote in an upcoming column about IMPACT MI, the problem in all of these three cases is not the drugs. The problem is that the comparators are so good. When an MI occurs, acute revascularization provides the vast majority of the benefit. Antiplatelet drugs reduce stent thrombosis, statins reduce future atherosclerotic events, and when there is left ventricular dysfunction, basic afterload reduction with ACE inhibitors provide the majority of benefit, and this is all good news. SGLT2 inhibitors have shown efficacy in certain types of patients. 2 large trials now show that post-MI patients are not one of those categories, which is fine. SGLT2 inhibitors help plenty of patients. Now, I want to conclude with one interesting observation from my friend and mentor, Dr. Sanjay Kaul. He had an interesting thread on Empagliflozin on Twitter, which I will link to. You need to look at this. He noted that we now have 3 heart failure trials, Emperor Preserved, Emperor Reduced, and Impulse, 1 CKD trial, Empakidney, and 1 post-MI trial, IMPACT MI, which show no mortality reduction with empagliflozin. In contrast, Kaul writes, a large and clinically important mortality benefit was seen in EMPA-REG outcome, which was a lower risk cohort. This was in patients with diabetes, and it was the first signal. And Kaul writes that I think we can now clearly say that the latter EMPA-REG outcome was an outlier. Kaul writes that, quote, large effect size, persuasive p-values, and high replication probabilities be damned. If it is too good to be true, then it probably is. He then links to an opinion paper he wrote in Circulation that is open access, and I will link to it. It's titled, Is the Mortality Benefit with Empagliflozin in Type 2 Diabetes Too Good to be True? This paper is really nice reading because it was written in 2016, 8 years ago. Kaul makes a Bayesian case that the remarkable 2.6% absolute risk reduction that was seen in EMPA-REG is likely to be real. But it's hard to explain mechanistically. Why did it work? And we need future trials to confirm, he writes. Well, now we have them in even higher risk patients. And boom, they don't seem to confirm the big mortality effect size and persuasive p-value. And I find this all so sobering, and I love it about medical science. So that's it for this week in cardiology. As always, I'm grateful that you listened, and it was so great to meet so many of you in Berlin. Thank you so much. Next week, I'll have more ACC Recap. There were many more interesting trials that we couldn't cover all today. And so until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.